Hello, everybody. Welcome back to the Practice Perfect podcast. Another week, another chance to listen to the beautiful Maya Turner and myself. Welcome to the show, Maya.
Hello, beautiful. It's Wednesday. Today is Wednesday. Today is Wednesday.
It feels like a Wednesday. It really feels like a Wednesday. I don't know about you. It's like allergies in my voice, just like so many meetings today. Shout out to my amazing project manager, our amazing project manager, Jessica Hazlitt. She keeps everything running and smooth. Whew, man. It's like it's nice to have somebody like her who is on it and keeps us on our toes. Reminds us when we forget to join the meeting. It's been what a week.
Yes. And she always reminds us to hydrate. Drink water. She
I
always
love
reminds,
it.
drink more
I do
water.
love it. Yeah, you got. I don't have mine with me. I'm falling down on the job here, but no, yeah, I love how she puts in my calendar hydrate in between meetings because like I'm gonna forget, and I do forget, so I have the reminder, which is really really great. So I'm excited for the rest of the week. See what happens. But today we're really focused on those 7 words we loathe to hear. But that's how we've
How we've
always
always
done
done
it.
it.
I mean, Maya, if you had to guess, how many times in your career have you heard those words? If you had to guess.
Way too many. If I had $1 for every time I heard it, I would really be a millionaire. And I've been in this
Mhm.
field for 30 years, and it's just it never it never ceases to amaze me. Just because you've done it that way doesn't mean that you've done it right. And it just is a terrible thing to say, especially when you're dealing with coding and compliance. It's just like,
Mhm. Yeah, it's
yeah.
true. Well, so my first experience with that was many years ago. And I work with physicians all the time, and I never heard that from any of them. It was more about, hey, let's talk to Jennifer about it. That was the cool thing that I had with my surgeon I was with for so many years. And then when I ventured out on my own, started my own billing company, started to get into consulting, I had a surgeon. And that's the first time I heard it. And he was in ophthalmology. And he had practices before this one. And, we were looking at some documentation and they had the templates, right? The surgical templates. And if I could show you this template, Maya, oh my goodness, it was like so
Mm-mm.
bare bones. And with some of like, I don't know if you know ophthalmology. Well, yeah,
Yeah.
retina. So it was for an eye stent. And we know that those procedures require a certain level of medical necessity to be proven, right? You got to prove the medical necessity. And those specific codes were, as we know, category 3 codes at the time. And so it's really, really, specific. And so what we had to deal with a lot of was talking to some of the reps at those companies, and they would give us reimbursement, information. We would look up the policies, and yeah, you had to be very specific about the glaucoma. And
Yes.
what did I get? Very unspecified glaucoma.
Yep. Mhm. Mhm.
We
Mhm.
always got paid, but did you?
Not really.
But
Mm-mm.
did you?
No, you didn't. Not really. All those surgeries they got billed, but they didn't get paid. So I think, and especially with dealing with retina, and I dealt specifically with macular degeneration and those types of
Mhm.
diseases
Yeah.
where, in order for you to do the angiogram, you still had to get special approval because of the eye, and especially if they had, the senile glaucoma,
Mhm.
and they had to prove that. And one story, they didn't check all of the allergies, and one of the
Mhm.
patients expired on the table because they had an
Oh,
allergic reaction
oh
to the eye.
my.
Yeah,
Oh, it's
yeah,
so sad.
yeah. So I mean, that's why you do those types of things to make sure that someone reviews the medical necessity and all of the I's are dotted and the T's are crossed to make sure that they are capable right, of
Yeah.
withstanding that type of surgery. But in that particular instance, yeah, the patient expired on the table during an angiogram. Yep.
Wow, that is so, I mean, that really makes you think about how important our jobs are too. You know, earlier today I was presenting for McVeigh seminars. Shout out to McVeigh seminars, on my quarterly ENT presentation that I do every quarter. And one of the things I mentioned, I like to mention in all the specialties I do, updates for, is where we're at with, AI and different things. And one of the things that you and I have been talking a lot about with our externs, our extern group, is understanding that AI is not going to be able to be effective without good documentation. So we always use that term garbage in, garbage out. It's only
Yes.
going to be able to pull information from the record that is accurate, and it's going to be able to translate from that information. It can't just make stuff up, right?
Right. Exactly.
It's going to
Yes.
pull data that's actually there. So when we look at, trying to train coders and, auditors, is that you have to be able to find these things, even if they're not reimbursement related. These
Mhm.
are things that affect the patient's life and their compliance from a medical record standpoint. And it may not even have to do with billing. But if you see something, say something.
Yes,
You know,
yes.
could have been caught, hopefully, if someone had paid attention.
Yeah, I mean, and I always say, I mean, even when you're dealing with AI, right? I say this all day, every day, in my words twice on Sunday, is that AI is supposed to augment the services of the biller and the doctor. It should never automate. It should augmentate, but never automate. And
Mhm,
I was just speaking with one of our colleagues. I was just talking to a lady, and she says that they're using a new system and they're suggesting, right? But again, they can
mhm,
only suggest. But if the code doesn't support what they're suggesting because they're only pulling key terms that could be interrelated with something else that might not be as specific, you could be in turn billing for a wrong service that may have already been pre-authorized, and then you're going to cause a denial because that's not what they authorized for, and that's not what the documentation is supporting. So, I mean, just because we've already authorized it, or we've already done that, or we've always done that, doesn't mean that it's always going to be supported when you bill it. And that goes back to quite a bit of things that we've talked about before.
absolutely. Well, I had a doctor come to me. We were having not a disagreement, but just a conversation about the proper code for a certain procedure. And talking to different colleagues I know in that specialty, we we know that typically, at least right now, an unlisted code is what we have for this particular technique that was used.
Right.
And so I explained that's what I currently am researching. This is what we are currently finding, and shot back with an email. And I could tell it was Google AI because I've used Google AI just to check, and I knew exactly what it looked like and that she was spitting out to me Google. But a lot of people don't realize that when you type in, like, what is the CPT code for this in Google, at the very top, it like starts spitting out stuff because it uses AI, right? So sometimes it's correct, or it will lead you to a certain, route that you can further research just to verify. And, remember, your CPT code book published by the American Medical Association is your source of truth for
Mhm.
matching a CPT code to documentation.
Yeah.
Now, that may change based on, you know, the payer, but our
Mhm.
source of truth for abstracting codes is always our official code set,
Mhm.
CPT or IC10CM, or
Yeah.
HCPCS level 2 if you're doing that. That's our source of truth.
Yeah.
So what starts sprinkling down your screen at the very top when it starts to like appear, that's artificial intelligence, or, you know, it's what we call generative AI, where it's kind of like ChatGPT. It's pretty much their version of that within Google. And so that is happening,
A
but it's
lot.
not always accurate.
Mhm.
I will say sometimes it's really great. Like it spits out stuff. I'm like, ooh, I like the way they said that. Like that's
Yeah.
really good.
Yeah.
And then today I was looking up something for somebody. Just wanted to get some ideas on where to go, because sometimes as coders we have to get a starting point. We just want to get some research out there. It was totally off.
Yeah.
Like I was trying to like show somebody how to use it for, it was something with the hands, and it spit out something totally off the wall, like not even remotely related to what I was asking it. It's just, I laughed because this is what we're dealing with. We're dealing with
Yeah.
one day it's super smart. The next day it's like, are you on crack? Like, what in the world? Where did you get this from? Like, that's how I feel some days. Like, I don't know. I mean, I guess sometimes we're like that, right? Like, some days we were like, why did I do that? She's laughing over here, guys. She's just trying to get through this.
I wasn't
I
ready
love
for the
it.
crack scenario, girl. I wasn't ready for that. Oh Lord.
You got blunt Jennifer today. Sometimes, some days she comes out. I'm telling you.
Right, right, right. But I think, and it's really interesting how doctors don't know, especially when, it's an emerging technology that they're unaware of. But you got to think every quarter or twice a year, you have provider specialties that lobby for codes for emerging technology, right? So it's almost mm, it's almost like, okay, so that your provider organization represents this. Every twice a year, they have the editorial committee where provider organizations lobby for having a specialty code created for them. They test that technology, and that's why there is a section 3 in your CPT book for new and emerging technologies. And because of that, we need to realize that your specialty, especially if you're really embedded with that specialty organization, has those types of inferences that say we're lobbying for this code, we're lobbying for this procedure. So it definitely makes a difference in that providers may not be as in tune as they should be, but I promise you, if they are, they would know that there's a category 3 code that should be submitted. And whenever it's submitted, it should be accompanied with medical documentation because it's new and emerging technologies and they have to prove that it works.
Absolutely. And there's a whole separate process on that. I think that'd be a fun episode, right? Explaining how
Yeah.
you get a code approved. That'd be fun.
Yeah.
Should put that on the docket. All
Yeah.
right. So I thought it'd be fun today just to go through like our brains and, think of just stories we've come across, things we've seen. And I recently was working with a set of procedures that I do often. And you know how we love when surgeons put the actual CPT codes on their op notes because they're always right and we're never going to change them. So we might as well just keep them on there because I'm going to type in what my codes are and no one's going to change them ever. Right. So
Mm-mm.
I had one that I was doing, it's like 10 codes on there all the time because it's a crazy surgery. And I was going through it and validating all of them. I get down to a couple of them and I'm like, wait a minute, what are these codes? And I looked them up. They were like 10 years old. Like they hadn't been active for a very long time. So my question is, how long have those been on there before we started coding for them? And the previous company or internal staff was coding for them. Were they just not putting them on there, or were they entering those codes and not telling the provider they were outdated? Like, is that what was happening? I don't know. But let's just say, for instance, they billed them on a claim. They weren't getting paid, but guess what? They were still done. They were just the wrong codes. So I mean, like, think about that. They were just not getting paid for that all this time. Let's just say for 2 years, this was happening. And then if you calculate the cost of those codes, it's like a couple $1,000, especially when you have several levels of the spine being done. And it's like, really? I was like, how much money did they lose over that 2 year period where now we're catching it? We're like, that's not the right code. Let me flip it to the new codes. You're still getting paid for it, but we're giving you the right codes that are actually payable in 2025.
Wow. That's unfortunately, it's not surprising because it goes on all the time, right?
Mhm.
And when you have people who bill and don't know codes and doing it robotically, where they're not reading the CMN, the latest LCD, or the element that comes out from CMS, right? That talks about the new technology. It's going to be something that happens all the time, right? I mean,
Mhm.
I can't tell you how many times where there was a delay, 14 days and a delay that was related to how the last biller did it. Um, you're supposed to send claims out every day, and you're supposed to check the claim status every day to make sure that it was accepted, and make sure you can follow up on that claim once it's accepted to make sure that from 14 days after it was submitted, there was a payment, right? But again, if you're just doing things robotically and not checking why you should be getting paid, or if you got underpaid, or if the code is even valid, then you're going to have a bigger problem, and you're going to be struggling to keep your business open.
Absolutely. There are a lot of things that aren't just coding related that happen in a practice. So, I mean, and people do things different ways. And so when you come into a new organization, for instance, you might say, okay, I do things a certain way in my last practice, but you come into a new one and they do things differently. So there's just like a weird example of like just on the copay collection side, right? Some organizations I've worked with, they will go ahead and they will just, if the patient has deductible and co-insurance, they will go ahead and they will just wait till the claim comes back and then they'll bill the patient, right? Others will keep a card on file so they can charge the patient when it comes through, right? Or they'll collect like half of it, right? And then they'll bill them for the rest. I mean, I wouldn't say there's necessarily anything wrong necessarily with any of that unless your state has a specific rule on how you collect. But every practice does things differently. Some people will wait to bill, I've heard, because they want to wait to see if it hits the deductible from somebody else. Like if another practice hits the deductible. So, but like, how does that make any sense to me? I don't know. You're delaying payment by waiting to see what happens. Have you
That
ever heard
doesn't
that?
Yeah, actually I have, especially when you're dealing with procedures, right?
Mhm,
The first 3 months of the year, you're gonna have deductibles,
mhm.
or you're waiting until they've met their out-of-pocket max, when you have a PPO. And for those of you who are not familiar with the out-of-pocket max, when you have a PPO, there's a certain amount that the PPO will allow to be out of pocket before they start paying 100% of the claim. And typically the number is like maybe 15, 2,500, sometimes a little bit higher. But once you've met that out of pocket max that's due co-insurance, any procedure that goes out after that is an out of pocket max, and that PPO plan will pay 100% of the claim. But again, it has to meet it. But some providers, what they do, especially if they're close to the end of the year, right? They want to make sure that they could get 100% rather than the 90%. But again,
Right.
contingent on appropriate billing, and one is also contingent upon if it's billed appropriately, right? And the medical necessity, because you could have something pre-authorized all day long, but if it's not meeting medical necessity in the documentation, it can't be billed. So there's a whole lot of caveats to that, but for the most part, that's what happens.
Yeah, I understand it, but at the end of the day, I mean, it's a lot better to submit your charges once they're ready. I mean, if everyone does that, then nobody is getting their claim in. So it's like, what if everybody did that? Like, I don't know. I just that mentality is just different to me. But yeah, you're gonna find that. You're gonna find where we've always done it that way and it's worked fine. But what if there's a better way? What if there is a better way to, find out that information? There's a lot of artificial intelligence or automation tools that can pull that stuff for you and let you know where the patient is sitting. And so there's a lot of things now you can do that are more efficient than we've always done it that way, right?
Hmm.
Um,
Hmm.
let's talk about contracts. I mean, we love talking about contracts, right? So practices that haven't reviewed their contracts in 8 years. I've seen longer. Now, I understand rates are horrible right now. So maybe you have an awesome rate right now. But what else is in your contract that might be hurting you besides the rate?
And it's ironic that you're talking about that because I'm speaking on that at the Medical Cost Containment Summit that's coming up in September. And again, one of the things that is really key about your contracts is, one, that they're paying you, two, that they're paying you on time, and three, that they're paying you at the rate that they're supposed to pay you. Now, again, if your contract is more than 5 years old, that means you're probably under the market rate. And based upon the Medicare physician final rule, and this is mind blowing, Jen, and we're going to be talking about this, right? It's mind
Mhm.
blowing that Medicare has not changed their rates for certain services since 2005. They're using the same rates. Why? Because they're sending out respondents, they're sending out surveys, and nobody's filling them out.
Of course. Why would I do that? I don't want to help Medicare.
2005, 2005. They haven't changed the rates because physicians are not responding. So that's 20 years old. Think
Yeah.
about what you paid for gas 20 years ago versus what you're paying now. Just
Crazy,
saying.
crazy, crazy. Well, I know you and I are helping a practice on the West Coast right now, who is part of an ACO. And over there, it's very heavy with different, organizations that are managed service organizations or they're, physician organizations. And so these organizations, you go into a contract with them because they can supposedly get you better rates, which is why most people go in there. But then you find out after so long that all your 99213s are getting paid at $60. And I have the contract in front of me. I have the rates that they secured for the practice according to the contract. They're supposed to be getting them. Actually, I think their rate was 110% of Medicare, which is unheard of right now. It's a great rate, but they're not getting it. So my question is, whose job is it to make sure that that money gets captured? Is it the ACO or the person doing the MSO actually doing the billing for them and then paying them from that? Like they're almost like like an employee, right? To this MSO. So they're responsible for making sure it happens. The practice is just now finding out about it, just thinking everything is going along just fine until it's not. And now we have to have a conversation about why they're not holding up their end of the deal, or at least not communicating to the practice with reports and, updates on why their revenue isn't where it should be.
There's a whole lot of ways that I could answer that, but I'm not going to say everything. I'll just say this. When you sign up for an MSO, which is a managing services organization, that's what that is.
Mhm.
They serve as a mediator between the provider and the payment. That's what an MSO does, right?
Mhm.
But if you're in charge of managing it, then you should be in charge of getting that money. Think of a managing an MSO as it relates to where you pay rent, right? A managing company who
Mhm.
manages who gets the rent. So if they aren't collecting the rent, whose job is it to collect the rent? The MSO works the same way. So if they're not getting the money, there's some liability that should be addressed that's associated with that payment. Think of it this way. Think of the MSO as like the union for the services that you're providing. That union should be able to stand up for your rights. It should be able to stand up for when something is wrong. And they should be able to keep you in the loop by newsletters, contacts, whatever. But if it's not happening, somebody should be held liable, right? My husband, he has a union and they contact him all the time. They send letters, there's a website, but if nobody's checking to see if they're up to date, then whose fault is it that you don't know that they're not? Uh-oh.
Yeah, it's true. I mean, I don't know how much plainer to say it. And there's also other things in your contracts that affect you. What is their rules on prior authorizations? What are your
Mhm.
responsibilities to collect copays? There's things that are your responsibility as an organization. They can come back and tell you that you're not holding up your end of the bargain. on this and vice versa. So really dig into those contracts, know what those fine prints are. I recently put an article out on Substack. I'm doing a lot of Substack writing these days, so check it out. I love writing on Substack. It's just like my outlet for just talking about stuff. So jump over to Substack if you haven't ever heard of it. It's a great place to find good content from revenue experts. Really great data people in healthcare are on there too. So it's really great stuff. But just think about that. Look at your processes. Are there any outdated practices that you want to look at? Nothing wrong with some of your processes that might, if it's not broke, don't fix it kind of thing. If it's not harming your practice, maybe it's fine. But what if it could be improved? What if it could, help you have money in your budget for a new fancy machine that could actually improve patients' lives, their quality of life? What if all that money could be used elsewhere? Are you still using paper? Oh, don't get me
Oh,
started on that. I know there's lots of practices who like to print everything out. And I try to train coders and billers to code without printing. I mean, sometimes it's necessary to get a piece of scrap paper out. That's great. But you don't want to be printing constantly. And there's a lot of these just, we've always done it that way kind of attitudes. And I'm like, but is it efficient? No, it's not. But that's just me. I mean, I can't understand the people that don't want to move forward and save the practice money, whatever it happens to be. But that's just me. And so if the only answer is you're getting because we always have, if that's the answer you're getting from somebody, then you need to make a change, because an organization that's their response is not interested in moving along with where healthcare is going, and they're not going to survive potentially, or they're going to get audited and then they're going to have a problem. Because I guarantee you the practices that are still saying that have huge red flags buried in their documentation.
or their revenue is $2 million and nobody's checking to see how much of that money is actually due or a credit for an overpayment. Uh-oh.
Mm-hmm. Oh, the overpayments. We got to have an episode on that. Oh my goodness. We got to dig apart that. That's insane. I have lots of stories on that one, by the way.
Oh,
So
hello.
So we've had some great fun dissecting this topic here today. And I want to let everybody know we're so excited on Monday. That is the Monday coming up, guys, on the 18th. We're going to have a special episode to dissect the proposed rule for the Medicare Physician Fee Schedule 2026 with Maya Turner and myself. And we're very excited to dig apart and really just talk about this. We've been itching to talk about this proposed rule, all the little nuggets and the not so fun things that are in it, but things we have to know. So stay tuned for that. We will not have a regular episode next week because we are going to be out of town next week, but we'll be returning for a regular scheduled episode on the following Wednesday. So stay tuned for that. We will see you guys Monday. We're going to dig apart this proposed rule, and we're really looking forward to it. So thank you for supporting the Practice Perfect podcast and always supporting Healthcare Inspired. Have a good week, you guys.